So far, we have looked at influenza, how to distinguish it from pneumonia, and how to treat influenza. We also looked at different types of pneumonia and how to use risk stratification tools. Now, let's take a look at causative pathogens for each type of pneumonia, including susceptibility profiles and patient risk factors for multidrug-resistant pathogens. Now, at this point, you should know that VAP is a more severe type of pneumonia and is associated with more resistant pathogens, and CAP, or community-acquired pneumonia, is a less severe pneumonia and less resistant pathogens cause it. Now, let's take a look at the common causes of community-acquired pneumonia. Viruses by far are the most common causes of CAP. However, when it comes to bacterial causes of community-acquired pneumonia, Streptococcus pneumoniae is by far the #1 respiratory pathogen causing pneumonia. Now, although Staphylococcus aureus can also cause CAP, not every patient needs MRSA coverage, and we'll talk about that more shortly. Now, there are a couple of gram-negative organisms that are likely to cause CAP, so Haemophilus influenzae and Moraxella catarrhalis. Of note, these two pathogens in the United States are likely to produce beta-lactamases. So that's important to keep in mind when we select treatment. And lastly, there are atypical organisms that can cause community-acquired pneumonia, such as Legionella, Chlamydia pneumoniae, and Mycoplasma pneumoniae. Now, when it comes to nosocomial pneumonia, you're more likely to have multi-drug-resistant organisms causing HAP and VAP. Of course, Staphylococcus aureus is one of the #1 organisms causing nosocomial pneumonia, and in this case, often the strains are MRSA. And of course, just like CAP, Streptococcus pneumonia is the #1 respiratory organism that can also cause pneumonia in the nosocomial setting. And when it comes to gram-negative, we have some of these multi-drug-resistant gram-negative rods. So Pseudomonas aeruginosa, as well as Klebsiella pneumoniae and Acinetobacter species, which often tend to be resistant to multiple drugs. Now, let's take a look at the CDC Epic Study that was published in 2015, and it was a population-based surveillance study for community-acquired pneumonia requiring hospitalization among patients adults 18 years of age or older in 5 hospitals in Chicago and Nashville. Now, this study looked at 2,320 patients, and what they were trying to do is to identify common causes of community-acquired pneumonia requiring hospitalization. Now, as you can see, in general, no cause is found in more than half of the patients who are hospitalized for CAP in the United States. The second thing that you will find here is that viruses are actually more common than bacteria. So you can see here human rhinoviruses, influenza, coronaviruses. And while Legionella and Enterobacterialis are found among hospitalized patients, really they are rarely found in outpatient community-acquired pneumonia. And what I mean by that is community-acquired pneumonia that's not severe, that can be treated outpatient. And we'll talk more about that shortly. Now, here is information from 2 different guidelines. The first guideline is the Hap and Map Guidelines. So here they have identified risk factors for MRSA in Hap and Map, as well as risk factors for multi-drug-resistant Pseudomonas in Hap and Map. So the common risk factor for these two is that if a patient has received IV antibiotics in the previous 90 days, that is a risk factor for selection for MRSA, as well as selection for multi-drug-resistant Pseudomonas. If someone has these risk factors, they should be covered for MRSA and for multi-drug-resistant Pseudomonas. Now, for multi-drug-resistant Pseudomonas, also 2 other risk factors include mechanical ventilation as well as history of chronic obstructive pulmonary disease. Now, when we look at the guidelines for CAP, you can see that for MRSA or Pseudomonas, they actually recommend to use a locally validated risk factor for either pathogen. So it really depends on the hospital because they couldn't find a validated risk factor that will work across the country. And one strong risk factor for MRSA or Pseudomonas is actually a prior history of isolation of these organisms, especially if it's in the respiratory tract. So if somebody had a sputum culture in the past that actually grow Pseudomonas or MRSA, then the next time that patient has CAP, they're more likely to have Pseudomonas or MRSA. Even if it's not a sputum culture. So let's say if someone had a urine culture or a blood culture that had MRSA or Pseudomonas, when they get CAP, they're more likely to have MRSA or Pseudomonas. And of course, because Streptococcus pneumonia is the #1 cause of community-acquired pneumonia, there are also risk factors for drug-resistant strep pneumo. So comorbidities, specifically chronic heart disease, such as heart failure, chronic lung disease like COPD, chronic liver disease like cirrhosis, and chronic renal disease like CKD, these are likely to select for drug-resistant strep pneumo. So you can see that these patients, including patients with diabetes, alcoholism, malignancy, and asplenia, they're more likely to be exposed to healthcare settings. So they're more likely to be resistant, to have at risk of having drug-resistant strep pneumo. Here I have listed the common antibiotics used for treatment of pneumonia. Now with Streptococcus pneumonia, I have broken it into 2 columns. So one is a wild type strep pneumo, and what I mean by that is that this is Streptococcus pneumonia that you are likely to find in a healthy individual without risk factors for drug-resistant strep pneumo. And then there's a column for drug-resistant strep pneumo, and this is the isolate that you are more likely to isolate in someone with those comorbidities. For Staphylococcus aureus, of course, we need to distinguish between MSSA and MRSA, so it's important to know which one we need to cover, because you can see many beta-lactams cover MSSA but not MRSA. And then for gram-negatives, H. flu and Moraxella catarrhalis are 2 common ones, so it's important to see which ones cover these. And then we have Pseudomonas as well as atypical cover, so you can see which antibiotics cover atypicals, in particular fluoroquinolones as well as tetracyclines and macrolides have excellent activity against atypical bacteria.